on, everybody? Welcome to yet another episode of the Core Consult RX podcast. Cole and I are once again without our buddy AJ.
It's just us.
He's too busy living that good life, being on vacation.
It's nice because it is cold and wet here.
It is.
Like miserable.
I guess cold's relative, though.
We're going to Atlanta for Christmas, and the high is like 20 degrees, which for many of you around listening, I'm sure that's not that bad. But
for us,
it's like
that is preposterous.
Miserable.
What do you mean I can't wear shorts? It's December. Yeah, no, it's crazy. I will say when I was in March, we went to Colorado to go snowboarding, and one morning we went to go snowmobiling, and this up the mountain somewhere, and it was like, I want to say it was like negative. Something preposterous.
It shouldn't be in the negatives.
It was so cold. I was like, what planet are we on?
Anywhere where it's in the negatives should not be inhabited. I saw the kickoff temperatures for for multiple NFL games yesterday, and 3 or 4 of them were in the negatives.
Yeah, that's where I go, well,
where I draw the line.
Here's my jersey. See you guys when we're back south. But I'm hoping AJ's enjoying his vacation, so good for him. But unfortunately, Cole and myself are graduates, so we don't get to
vacations for us.
We don't get to have fun. So here we are with you guys. I know it's been we haven't had as many episodes released this month, but we're gonna hopefully squeeze another one in probably before this one actually gets released. But it's December, so hopefully you guys can forgive us or find a better podcast to listen to in the first place, right? So today is another accredited episode, and once again, we've partnered with freece.com. And so for those of you who are members of freece.com and have an unlimited membership, so you have access to all their content, that includes our podcasts. And so after you listen to the podcast, we're going to give you a password, and you will go to the website. We'll have a link in the show notes. Take the post-activity test, and then you'll receive, assuming you pass the test, that is, then you will get 1 hour of continuing education credit for pharmacists and nurses. And if you're not a Free CE member, I highly suggest that you check out their website to look at all the content they have. They have a lot of really great stuff. And there's also a link in the show notes for a discount off the fee of the annual membership. So appreciate them, as always, for working with us. Today's episode is something I don't know that we've covered specifically, or at least if we have, it's been a while.
It's definitely been a while if we have. Some of it sounds familiar, but maybe. I can't remember. We're
going to be going over insomnia disorder.
Yes.
And so in celebration of that, the password for the post-activity test will be SLEEP. SLEEP in all capital letters, and that will give you access to the test, which will be grueling.
Brutal.
Probably not. But so we're going to cover insomnia disorder, and like always, we'll kind of start off with some basic background information, and then we're going to kind of go through step by step some of the treatment classes that we have, and then kind of at the end, we'll talk about a meta-analysis that came out this year that wasn't too surprising, but kind of gave us a little bit more insight on how to pick and choose between some of these agents.
I meant to ask, do you have trouble sleeping?
I don't. So when I have a terrible sleep schedule, as you've pointed out before on the podcast, but when I actually lay my head down to go to sleep, it takes me maybe 20 seconds to fall
very
asleep.
Nice. I'm similar. I mean, not 20 seconds, but within a couple of minutes. But I have multiple friends who have a lot of trouble sleeping, and I don't know, not too much. Apart from like very serious illness, sounds worse to me than just laying awake all night. I mean, sometimes I go through periods where I'm really stressed or something and my mind just can't wind down, but generally I don't have trouble.
Usually for me, if I have trouble sleeping, it's not necessarily stress. It's usually because I'm thinking about something with the podcast.
That's true.
Or something.
It's because you're right. It's not necessarily stress. It's because I'm really excited about something. So then I just end up on my phone looking up stuff.
That's exactly.
And then I try to lay down, and all I'm doing is thinking about that stuff. Yeah, that's a good point.
Which, as you'll find out, it's not great sleep hygiene.
It's terrible.
It's the worst way to do it.
So,
but I guess I always say, like, when people are saying, "Oh, you should be on your iPad or doing this, that, and the other," I'm like, yeah, but I don't have trouble when I decide to go to sleep. Mine's just probably not overall for my best. Health.
It's not the best tactic, but I'm like, I'll wait till I have trouble sleeping to fix those things. But it's probably similarly like with my diet. I'm like, I'll wait till I have high cholesterol to fix those things. But that's not the way.
Next thing you know, I'm on a statin.
Yeah, I'm on a statin. That's what they make them for.
Yeah, it's true. So insomnia disorder, I guess we'll start off with, sort of like the sleep cycle. We're all have heard this, some way, shape, or form along the way, but it's something that I had to review myself, and something I don't think about on a day-to-day basis. But just a kind of brief overview. The first big sort of subcategory would be our non-rapid eye movement, or NREM sleep, which is going to make up of roughly around 75% of total sleep time. In that non-REM sleep, you have what's called stage N1, which is the transition state sort of between wakefulness and actually falling asleep. Stage N2 is the lighter, what they refer to as alpha wave sleep. It's going to be characterized by like sleep spindles, K complexes, if you were actually to have somebody doing a sleep study and monitoring their brain function while they're sleeping. And N3 is the last stage of non-REM, and that is delta sleep or slow wave sleep. That's going to be considered the most restorative sleep. It's going to help promote protein synthesis, wound healing, things like restoration of the immune function, the stuff that obviously our bodies really need sleep for in the first place. Then we have rapid eye movement, or REM sleep, which is the other 25% of your overall total sleep time. Possibly this plays a role in memory consolidation, and can aid with sensor and motor system development, things of that nature. There's if you're really interested in like sleep, neurobiology and whatnot, there is a guy named Matthew Walker who's from the UK. He's basically a sleep scientist. I've heard him on multiple podcasts. He's got his own podcast now. He's got books out. He's one of the smartest guys I've ever heard talk about sleep, and he explains the most detailed, easy to understand explanations of this type of topic I've ever heard. So check him out if you want to. He's really great. I want to say I've probably messaged him a couple times trying to get him on here, but he didn't write back.
Smartest ones never do.
It's very pretentious between us.
And the smartest ones, they always make it easy to understand.
They do,
They're good at explaining.
But if only he would come hang out with us on the podcast. But
well.
I guess, he's got more important things to do, like running a lab.
I have to say that I love sleeping. Like, I love sleeping. In the morning, all I want to do is not get up and just sleep some more. But at night, I do everything I can to postpone going to sleep.
I'm the exact same way.
Absolutely. I mean, any excuse I can find to not go to sleep.
I despise going to sleep at night.
I hate going to bed, but I love sleeping.
I like when I'm laying there and I'm really tired and I can fall asleep. But the fact that I had to stop whatever I'm doing that I'm into that night and like go to sleep, I fight it. And then I get up in the morning and I hate my life.
What if we just didn't have to?
I think that they've tried that. I think it didn't go. I think it didn't go
For
well.
10 days it worked out, and that was about it.
Yeah.
So insomnia has a definition, and it's important that we distinguish what insomnia is versus other issues. We'll talk about that with the diagnostic criteria, because insomnia isn't just trouble sleeping. Like, not all instances of trouble sleeping equals insomnia, especially if it's related to something else. So its actual definition is the inability to initiate or maintain sleep, and can also be associated with problems or associated symptoms during the daytime. It's kind of split into two facets depending on the length of the person's insomnia. There's acute insomnia. Sometimes it's called adjustment insomnia. Of course, this is when symptoms are present for a shorter period of time, specifically less than 3 months. And usually it occurs in response to an identifiable stressor or life situation. And that's acute. And you'll see that, not always are we having to initiate pharmacotherapy in those instances. Chronic insomnia would be symptoms that occur at least 3 times per week and that persist for greater than 3 months. And of course, going back to the definition of insomnia, it's usually going to have effects during the day as well.
And once you get to a place where you are going to say, okay, this patient is suffering from more of a chronic insomnia disorder, then you would want to sort of further subcategorize that into either isolated sleep onset insomnia, which is basically difficulty falling asleep in the first place. So by definition, it takes greater than 30 minutes to fall asleep. That would be isolated sleep onset. Then there's sleep maintenance insomnia, which is difficulty sleeping, through the night, or you're waking up too early in the morning and can't go back to sleep. And that would be, by definition, being awake greater than 30 minutes after waking in the middle of the night. So you can get to sleep just fine, but when you wake up, it's very hard to go back to sleep. And then we also have mixed insomnia, which is basically the patients have issues with sleep onset as well as maintenance, which is probably the worst situation to deal with because obviously there's limited options there for treatment. And we will touch on some potential strategies for handling that as we go.
Yeah. So as far as the diagnostic criteria, I said it's kind of particular. In general, the primary complaint would be a dissatisfaction with sleep quantity or quality associated with one or more of the following symptoms, because it can't just be quantity, because I have complaints about sleep quantity, but that has nothing to do with insomnia. It's just because I'm not in bed long enough to sleep enough. So you'll see how we kind of distinguish those things. But one, like Mike said, the individual would need a difficulty initiating sleep. In children, interestingly, this may manifest as difficulty initiating sleep without a caregiver's intervention. One thing I've been warned about, which I haven't done yet, is like letting your kids sleep in the bed with you, if they have a nightmare or something like that. Because it's like just a horrible habit to like break when it gets there.
Same.
But then I have friends who like that happens and I'm like, oh my goodness, it's going to be really difficult.
I go, a nightmare? So you're scared of something that's not real.
That's what you're going to tell your 2-year-old?
That's what I'm telling my son. As soon as he's of age.
He's going to say, Daddy, it's those scary Star Wars monsters that you let me watch.
I'll go, you chose to watch them. Because I subliminally made you watch them when you were 6 months old.
6 months. So difficulty initiating sleep, difficulty maintaining sleep, specifically characterized by frequent awakenings or problem returning to sleep after awakenings. A lot of times people may say being awake for more than 30 minutes, kind of similar to the 30 minutes of falling asleep. Early morning awakening, and then the inability to return to sleep. That is never an issue that I've had, just waking up too early. My issue is I'm always waking up too late and running out the door to work. My whole life, it's been that way.
I've yet to woke up before my alarm clock.
I know. Never. Actually, when I was in high school, if my brother woke me up before my alarm clock and I looked and it was just about to go off in 3 minutes, it would make me so mad. You stole those 3 minutes of sleep from me.
How dare you? And plus you got to count the fact how many times you're going to snooze it.
I know. There's at least 25 to 30 minutes of snoozing. I legit do 30 to 40 minutes of snoozing, to this day. It's hard.
Oh, yeah, I do too. And
I cannot get up.
You know that dude, the Navy SEAL guy that does the podcast, the Jocko Willink? Mm-hmm. He made a comment one time. He's like, just think, when you hit that snooze button, the first thing you did that day was fail. Hey, you don't say that, Jocko.
It's too true, though. And
it is so true.
It's awful because I'm it's not like I make a conscious decision. I am not coherent when I press the snooze button the first 3 times. I don't know what's going on. And I know it's my own fault. It's self-inflicted because I'm not going to bed on time.
Right.
And what's worse is for those 30 to 40 minutes of snoozing, I'm not getting good quality sleep at all.
I'm getting angrier by the second.
Exactly. So something needs to change. I had whittled it down to 20 to 25 minutes, and now it's just made me late for work because I've extended it back to 40. It's horrible.
Yeah. Sometimes I wake up because I don't hear my alarm at all. I wake up to a pillow to the head because my wife's like, why is that going off still?
Anna's a little more subtle, but definitely a lot of trying to wake me up in the morning.
Anyways.
So next would be and this kind of falls under extra things with the diagnostic criteria, but the sleep disturbance causes significant stress or impairment in social, occupational, academic, etc. functioning. Occurs 3 times per week, like we said with chronic, lasting for 3 months, and then it occurs despite the adequate opportunity for sleep. So that's what I was talking about is important. I do not have insomnia because I'm not giving myself an adequate opportunity to sleep. So they have to you have an 8 to 9 hour period that you're available for sleep, but you can't get that much sleep. Mm-hmm. And then it's not better explained and does not occur exclusively during the course of another sleep-wake disorder. So narcolepsy, that would be sleep issues related to narcolepsy, not insomnia. Sleep apnea, that would be issues with sleep apnea, not insomnia. Parasomnias, those sort of things. Or if it's attributable to substance use or medication, that would be different. Or pre-existing mental disorder or other medical condition that's causing it, it would be associated with those other disorders more so than calling it insomnia.
I can't figure out why I can't fall asleep. I mean, I just do a little bit of crystal methamphetamine late in the afternoon. I'm just wide awake.
I do it at least 3 hours before bedtime.
I give myself space.
I give myself a buffer. It's right after I drink the huge cup of coffee.
Exactly. So some other things that are important to kind of specify when you're actually giving someone a diagnosis, and this is more getting down to the nitty gritty, like documentation process, but this is all coming from like DSM-5. They want you to kind of specify if it's episodic, so symptoms last at least 1 month, but less than 3, persistent, so they've been lasting longer than 3 months, or recurrent, so you've had 2 or more episodes separated, between each other, but it's happened within this time frame of a year. And then the other thing that they want to kind of take note of is there other, a mental disorder, like substance abuse disorder, something like that, some kind of other medical condition, another sleep disorder, restless leg, things like that could also be a factor, because they want you to be very specific with the diagnosis, because historically it's just been one of those things people just say, oh, insomnia.
And especially with the acute or short term,
yeah,
since that is generally related to something in particular, they want you to associate that with something.
So definitely a very long, which I think is important to kind of see too, because I feel like sometimes when we think about the diagnosis of certain behavioral health issues, we kind of just assume there's like 3 things to look for. Oh, this person has it. But then there's so many other subcategories you have to consider. And
we just boil it down to trouble sleeping. It's like, I've got insomnia. Right?
Well, I mean, just because I play Call of Duty while I'm in bed, I can't fall asleep.
Do you have a TV in your room?
Yeah.
I'm not allowed.
No?
No.
I do.
I don't know that I'll ever be allowed.
I will say, I don't think we watch it that often. But we do have. We used to.
It's just having the option.
We used to be really bad about that when we first got married, when we were younger and stuff. And we used to absolutely have the TV on all the time. And but the thing is, I can sleep totally fine. I don't know if it's the best quality sleep, but I can fall asleep instantly. When I'm really tired, you could have a marching band in my room, and I'm gonna go, okay, guys, have fun.
Well, we of course didn't grow up with one in our bedroom, and so that was just a huge perk for me when I got to college, was to be able to, which I only had one room, so that
was your rebellious.
Yeah, that was my rebellious stage. I drank like soda and then had a TV in my room
at night. Oh, dude,
late. But
College
and so all through undergrad and pharmacy school, like we watched TV all the time in my bedroom. But I suppose those were like when I was getting the worst sleep of my life. So
probably
it's probably best that we don't have one, but I complain about it all the time.
You just need to put your foot down. Cool. See how that goes.
Yeah. We'll see how that goes.
Dude, I can't be in the podcast anymore.
She doesn't listen. It's okay.
That's good.
So, of course, with any condition, we're going to talk about non-pharmacologic. It is especially important here because while we're going to talk about some safer medications versus others, it's definitely preferred to try to first make concerted efforts to address the lifestyle situation, because this is definitely an instance where lifestyle plays a huge role. And if you really have all this stuff nailed down, I mean, it's going to help a lot of people. So if they have all these things nailed down, but they're still having trouble sleeping, medication. So there's obviously CBT. We talk about that for a lot of psychiatric disorders, insomnia as well. Cognitive behavioral therapy is the preferred treatment for chronic insomnia. This is after the acute phase, but I believe could help with the acute phase. Or did they specifically say chronic?
So I think it is more chronic, because at that point they're actually seeking help, and if there's a specific stressor, they may deal with it more on the anxiety side, which is still always important. I mean, ultimately, cognitive behavioral therapy, like you said, can address any type of behavior, or at least aid.
Right.
But they specifically they have cognitive behavioral therapy, like CPT-I, which is cognitive behavioral therapy for insomnia specifically.
Yeah.
So there is a specific type that is utilized for this, but it can be. There's a lot of benefits to it.
And it addresses common thoughts and behaviors that interfere with sleep, which seems to be my issue if I ever have issues. It's just my brain's running on overdrive.
And again, I think to keep in mind too, this is for people who are actively seeking help. For like please don't email us about all the things we're doing, because we're actively admitting that we need it, but I also don't have any trouble with insomnia. So that's the difference. I don't know, again, like you said, Cole, I don't know if that's the healthiest way to go about it, but this is when someone's seeking help, that's when this becomes a good option.
Right.
Don't just go be pushing CBT on just anybody.
Right.
Because then they won't want to be around you.
So they try to help with the establishment of a sleep and wake time every day, 7 days a week, and then stimulus control.
Wait, you mean I can't sleep in on the weekends and expect my sleep schedule to be perfect on the
I know.
week.
All I want is just one day to sleep, like Saturday. I just want one day where I can sleep in without an alarm clock. That's my big thing. Just no alarm is set, but I can sleep without anything waking me up. And I rarely get that anymore, especially with the kid and whatnot. But when I can get that, it's just magical.
The last time I did that, I learned my lesson. Because it was Saturday. I was really excited. I had a rough week. I was really excited to get some stuff done on Saturday. And I was like, you know what, though? I'm not going to set my alarm. And I laid down and I woke up. I was like, oh. You kind of wake up in the morning. I was like, oh, I feel rested. And I looked at the clock and it was 3 o'clock in the afternoon, baby.
Well, that would be wonderful, wouldn't it?
I was furious at myself the whole rest of the day because I wasted all time.
I would not see that as a waste at all. I'd be like, this is so amazing.
Bad. Well, plus, since my wife had been up since like 4 a.m. that morning, like working out, she's already has that. I'm like, oh, cool.
Yeah, my issue is that, I mean, both our issues now is that means if we're sleeping late, that means that the
no one's watching.
No one's watching the kid or the spouse is.
His survival instincts usually kick in.
I end up making up for that the rest of the day.
Yeah, I get it.
So yeah, stimulus control as well. So go to bed only when sleepy. That is an interesting recommendation because what if I'm like never sleepy? Like what if it's 3 a.m. before I'm sleepy? Anyways, go to bed only when sleepy. Use bedroom only for sleep and intercourse. If laying in bed for more than 20 minutes without sleeping, get up and try again later. And then no naps during the day, especially greater than an hour. And there's a number of other sleep hygiene related things that we've kind of been referencing related to screens in the bedroom or close to bedtime, exercising, and we'll kind of go over those more in particular in just a second. But that's specifically with what CBT addresses.
The other thing that can be a component of CBT for insomnia would be dealing with the anxious thoughts, which is a lot of times why people are having difficulty falling asleep in the first place, some kind of anxiety or stressor that's causing anxiety. But the cognitive behavioral therapist is good about utilizing techniques, everything from mindfulness and meditation to like progressive muscle relaxation and things of that nature, which are all backed by some, maybe not the highest level, but some form of evidence as far as being efficacious. The problem is a lot of people do not utilize CBT for insomnia strictly because, one, the cost, it can be expensive. Some insurance companies may not cover it. The time it takes to actually go meet with a therapist and then practice what you've learned during therapy. And also finding a good available CBT therapist that specializes or at least has training with insomnia specifically. And I will say, when we think of CBT, we always think of it as being effective for the vast majority of people, but there have been case studies and cohorts and whatnot that it basically shows that there are people who do not respond well at all to CBT for insomnia. It doesn't help, even though they've done some of these techniques and actually taken it seriously. It just doesn't, is not effective for them.
Right. So just to put a bow on the sleep hygiene, which I want to emphasize, because more than likely when you have a patient come in, especially if their primary complaint is trouble sleeping or insomnia, it's probably been going on for a long time. So their first answer to, well, have you tried adjusting your like bedtime routine and sleep habits? They're going to say yes. Like they're going to be like, yeah, I tried that. I did melatonin, I did all these things. But if you kind of know all the different components of this in the back of your mind, you can be like, well, did you do this? Did you do this? Did you do this? And you can give that a go where they're really strict about it before moving on, possibly. So we mentioned a few of them: maintaining regular bedtimes and awakenings. Don't go to bed unless you're sleepy. Sleep long enough to avoid feeling tired, but no more. So that's a bad habit I have if I get the opportunity. Optimize the bedroom conditions: light, temperature, noise. And if you have a spouse, I'm sure there will be some disagreement as to what that might look like. Develop a bedtime ritual that allows you to unwind. If you can't go to sleep or if you awaken and cannot go back to sleep, do not stay in bed more than 15 to 20 minutes. We talked about this. Get up and do something, then come back. Don't go to bed hungry. I never have that issue. But also don't to have a big meal right before bed. Try a small snack. Try to have your actual meal be like 3 to 4 hours before bedtime. Do not lie there and watch the clock. You could get one with a luminous dial, but looking at the clock is kind of an activating activity, so try to avoid looking at it. We talked about no naps, avoid caffeine and nicotine throughout the day. Specifically, just try to avoid caffeine after lunch. I think, I can't remember exactly how long the half-life is, but if you finish it around lunch, then you should get a couple half-lives before bedtime, and so hopefully the majority of it is out of your system to any significant degree to be able to keep you awake. Avoid alcohol because, of course, it's sedating at first, but can be kind of activating later on and can lead to fragmented sleep. And then exercising regularly is very beneficial, but just avoiding rigorous exercise close to bedtime or even just general exercise like 3 to 4 hours before bedtime.
The alcohol thing is interesting too, because you always hear people, at least back, historically, they've talked about the nightcap and all that. And now in modern day, you'll hear a lot of people, especially in states like out west and whatnot, where cannabis is legalized or medicinal cannabis, people will use it for sleep as well. One of the things that sleep expert was talking about, and a couple of his things I saw on him, he was saying that when you'll notice when somebody who does use cannabis or does use alcohol to help induce sleep, even though they feel like it really helps them go to sleep, when they come off of it, they start having like really vivid, crazy dreams, because it's like their body's finally getting to that deep sleep level that they haven't been able to. You just don't realize that the sleep onset happens quicker,
right?
But it's not good quality sleep.
Because what you thought your issue was rolling around for 30 minutes to an hour before you could fall asleep. So if it gets you right to sleep, you're like, oh yeah, it's working great.
But really, you're
probably still tired throughout the day, but you don't associate it with that because you weren't rolling around before falling asleep.
Yeah, it's pretty interesting.
Kind of unintuitive, but
makes sense.
It is. It does.
All right, so I guess starting with the medications, we'll kind of jump into the hypnotics, also known as our non-benzodiazepine receptor agonists. And if you're looking at like a picture of the GABA receptor, so GABA-A receptor, there's receptor sites for things like benzodiazepines, there's things for barbiturates and other non-benzo type entities, and they have different signaling responses and things like that when those agonists bind to those receptors or block those receptors or what have you. But our benzodiazepine receptors, we typically think of our benzodiazepine 1 receptor, which contains the alpha-1 isoform. This is going to be highly concentrated in the cortex, thalamus, and cerebellum. And it is going to be more responsible for like the sedative effects, as well as like amnesia that sometimes people report when they're taking certain hypnotic type medications. The benzodiazepine 2 receptor is the alpha-2 isoform. And that's going to be more concentrated in the limbic system, amongst motor neurons, and also in the dorsal horn of the spinal cord. And that is going to help to mediate the anxiolytic effects, as well as like the mild relaxant effects, such as like with true benzodiazepines and things like that. So a non-benzodiazepine, like the Ambiens and things that we're going to start off talking with, those are benzodiazepine receptor agonists, but they're selective for benzodiazepine 1, so the alpha-1 isoform, which is why you don't necessarily get relief from anxiety, or you wouldn't use something like Ambien for as a muscle relaxant component because it doesn't have that same activity at the other receptor.
It's funny that they're like officially classified as non-benzos because in every way, except for binding to a different benzo receptor, they are a benzodiazepine, I would imagine, right? It's just not in the traditional sense. That's why they're calling them non-benzos.
Well, I think it's because they're binding to they're more selectivity to one over the other. And
whereas traditional benzos are kind of non-selective.
Yeah, non-selective. And like they're also binding to like other things like propofol or barbiturates. They're going to be binding to different, not the benzodiazepine receptor necessarily, but like other parts of the same, the GABA A receptor.
I see what you're saying. So obviously don't get these confused with the benzos because while we would place these closer to first line in certain situations, the benzodiazepines we would obviously reserve. So one and the most common that you're familiar with probably is Ambien, zolpidem, binding to the benzodiazepine 1 receptor. So it has a box warning for complex sleep behaviors, including sleepwalking, sleep driving, heard stories of sleep eating, and all sorts of craziness.
I'll tell a story that Dr. Wayne Wirt, who's been on episode 100 and 200, told me that he had a friend of his that he knew, or a colleague, I guess, that had taken a zolpidem that was prescribed. I mean, and hadn't had any issues in the past with it. Took a zolpidem, went to bed, woke up the next morning, and thought, "Oh no, someone has broken into my house and destroyed my kitchen," and didn't know what happened. Come to find out after doing some research and looking at surveillance tapes and whatnot, got up in the middle of the night, left his house, got in his car, drove to the store, bought a turkey, went home, decided to make the turkey, put it in the oven, but didn't do any of the stuff right, and then just went back to sleep and like just wreaked havoc all over his
turkey.
Yeah.
Of all the things to buy, probably wasn't even Thanksgiving.
I would have gone with I don't know.
Where are you going to find a turkey at 2 a.m. when it's not Thanksgiving?
It's a good question. I would have definitely.
And who's going to sell a turkey to a man in his underwear who looks like he's
I imagine he got dressed, and because otherwise he would have been arrested, I imagine. But I would have gone with the Lunchables. It's way easier.
It's so much
easier to prepare.
And you're going to get an Oreo.
Yeah, maybe. Depends on the one you get.
Or a Butterfinger.
And a Capri Sun that you can't get your straw into.
Stupid straw through.
I hate that thing. Anyways,
I was eating those in college, by the way.
Were you? Good.
Yeah.
You say, the one cool kid who like flip it upside down and put it to the bottom. It's like, whoa.
Yeah.
Anyways.
It wasn't me. I wasn't that cool.
No. Be struggling in the corner with the regular style.
So there's obviously concerning things about Ambien. So with any of these, we just want to use with caution and make sure that we're counseling people appropriately about the concerns. It doesn't have any anticonvulsive action, no muscle relaxant properties, no respiratory depressant effects. So those aren't an issue. So the main issue with interactions and things would be with the CNS depression. There is different dosing for males and females and elderly patients. So you would recommend maybe 10 milligrams for a younger male, 5 milligrams, so half the dose for female and elderly patients.
Which almost never happens.
Never happens, and I would see this all the time for a new start Ambien female or elderly patient starting on 10 milligrams, which was,
Yeah.
Might as well start. This was another feature that we haven't referenced, but starting at the lowest dose and trying to find the lowest effective dose for any of these that we're going to talk about is what you want. There's no goal dose that you need to get to. So take it on an empty stomach. Food does delay the action by about 1 to 2 hours. It, of course, has the immediate release, which we have efficacy seen for up to 35 days. It has a controlled release tablet with efficacy seen for up to 6 months. And then some tolerance develops.
Without tolerance developing.
Sorry, without tolerance developing.
Because I think that was the big push. If you are going to be on it more chronically, they want you to use the controlled release, which is usually the opposite of what we think of for like opioids and things like that.
Right. Interestingly, a lot of the studies with, we might talk about this with a meta-analysis, I'm not sure, but a lot of the studies with these sleep medicines are very short.
Yeah.
And so
it's almost like they're designed for short-term use.
That's what you would think. So we just don't have a lot of long-term safety and efficacy data on them. There's also a sublingual tablet. These are branded as Edluar. That is an awful one to say.
Yeah.
An intermezzo. They're 1.75 and 3.5 milligram doses. These are for middle of the night wakenings with at least 4 hours of sleep left. So generally you would think of like an immediate release Ambien as for sleep onset. This would be for middle of the night awakenings. There's also a sublingual spray called Zolpamist that you can prime before the first use. I've never seen either of those, by the way.
Yeah, I think you have to prime it after the first use, or I think it's after 2 weeks if you haven't used it, which who in the world's letting that sit there? Yeah. But like 2 weeks later, you would, if you haven't been using it, you'd prime it again.
Drowsiness, dizziness, headache are the side effects, along with the other, crazy things at night. And it is a controlled substance in America, a class 4 controlled substance.
So the next one is S-zipiclone, or S-zopiclone, I should say, Lunesta. We all remember the commercials with the lunar moth. And mechanistically, it's similar, but it does seem to be a little bit different. In fact, I don't think they're 100% sure exactly how Lunesta elicits its effect, but it does interact with the GABA receptor complexes. In this case, though, it's more binding allosterically with to the benzodiazepine receptor. It does have high affinity for the alpha-3 subunit on the GABA receptor, so it's a slightly different mechanism, which I will say there is cases where if Zolpidem doesn't work, switching to Lunesta is not giving them something that's directly in the same class. They do have slightly different mechanisms. So I have seen that be an effective strategy if Ambien's not working in a patient. It does still carry the box warning for complex sleep behaviors, sleepwalking, sleep driving. Sleepwalking sounds way better than sleep driving.
I imagine that if they compared that to drunk driving, it would be just infinitely worse.
Oh, it has to.
How can you sleep drive?
Unless you have a Tesla, I feel like sleep driving cannot be safe.
Another reason for a Tesla, but that's one of the stories that I heard was like a guy going through the McDonald's drive-through and going home and then eating his takeout. Like if you can make it through the McDonald's drive-through, remember your order, and get home and eat. That's significant.
I mean, if you can do all that, like you're a Jedi.
Yeah.
I mean, that's pretty impressive.
I imagine that it's more that they don't remember it versus that they were actually in a truly sleepwalking type state that you see like on TV when they're walking around like a zombie. It's probably just the anterior grade amnesia that they don't remember they did it.
Yeah, well, let's hope.
But they also, I guess, have to be incapacitated enough to not realize that they're doing something crazy. So I guess, I don't know, it's nuts. It's just
hopefully
nuts.
every one of those stories, they were in a Tesla and everybody was safe driving. This episode is sponsored by Tesla. Yeah, could you imagine? You should be taken immediately. We're going back to Lunesta. Sorry, our tangents are going to distract everybody. It does need to be taken immediately before bed. And the patient needs to hopefully ideally have around 7 to 8 hours, so a full night's sleep when they're taking it, because it does have a little bit longer half-life. Same thing like with Ambien, you do need to take it on an empty stomach, because if you take it with food, that's going to delay the onset of action, which means that you may still have some of the residual effects in the morning. Some of the common side effects, drowsiness, dizziness, headache. Also with Lunesta, it's often reported that patients will experience like a metallic taste, which will go away once you stop taking the medication, but it can be very annoying for people who do experience that.
Right. Then there's Zaleplon, branded as Sonata, very similar in mechanism of action and adverse effects to Ambien. Similar box warning for sleep behavior, sleepwalking, and driving. It does have a shorter half-life. It's about an hour. So it might cause less problems in the morning if a person is experiencing drowsiness throughout the morning despite a full night's sleep. It does not prolong sleep time or number of awakenings, but it might be a good as-needed option for middle of the night awakenings.
Yeah. So the studies, they basically showed that it wasn't effective for keeping you like overall like treating your insomnia, which is why we hardly ever see this one.
Right.
But I will say I've personally used this in patients where they were on a reasonable dose of something like Ambien, and then like we give them like 10 tablets of Zaleplon as well, and then they use that PRN, and it really does work well.
Take it on an empty stomach as well, which I don't know if you're going to be eating. Well, you might eat during a nighttime awakening. And the efficacy has only been seen for up to 30 days. So another kind of short-lived trial, that we would hope to use for short-term use, but it doesn't always happen.
Yeah. All right. So instead of those non-benzodiazepines, let's talk about benzodiazepines. And we're not saying this is we'll talk about the order in which to use.
This is not in order of what we would use them.
This is just the order of which we felt like talking about. So benzodiazepines, in general, they are considered to be quote-unquote safe and effective. Again, this is assuming that they are being used properly, short-term, lowest effective dose, all that
because
stuff.
they have an FDA approval thing,
that's
they
where
have
the
to be
safe,
quote-unquote considered safe and effective.
Exactly. That's a little caveat
for
there.
this indication.
Yeah, it does not mean tripling the dose and taking them like crazy.
Right.
Not safe then.
Along with opioids and alcohol.
Right. So oftentimes, though, they are not going to be considered first line. Basically, 5 of them are primarily used as sedative hypnotics because they are rapidly absorbed. They produce central nervous system actions more quickly than most other anxiolytic agents. Someone that has problems initiating sleep would most likely benefit from an agent with quick onset but a short duration of action. Someone with problems maintaining sleep obviously is going to maybe benefit better from a benzo that has a little bit longer half-life, maybe a little bit slower onset. That being said, the typical benzos that we see in practice, Klonopin, the alprazolam, those are really not the ones that are actually like approved or like designed for insomnia. So some of the ones that we kind of break them down into the duration. So we have the short duration, intermediate, and long. The short duration would be triazolam, Halcyon. So that's the one that, in my experience, I typically have only seen like dentists utilizing those for like procedures for patients who are really nervous about something.
I'll see them before MRIs too.
Yeah, exactly. So usually it's like that, but it is a very short. It's a 2 to 6 hour half-life. So I mean, not super short, but and then a fairly low dose. Temazepam is the other one that I've seen people be on. That's considered an intermediate duration of action benzo. And then we get into, we have one more intermediate, which is estazolam. And then we have our 2 long-actings, flurazepam and clozapam. which I think we had talked before we started recording. I think we've heard of like maybe one patient being on flurazepam, but the half-life for the last two that I mentioned, flurazepam and clozapam, is variable. It's 48 to 120 hours.
120-hour benzo.
Most people would consider that too long to be on a benzo.
Most reasonable people may.
So that's one dose. But, mechanistically, all of these are going to be working. They're binding to the benzodiazepine receptors on the postsynaptic GABA neuron. They are going to help to decrease sleep latency and increase stage N2 or sleep, and then also the time of total sleep. It reduces delta sleep and REM sleep. So when you hear people talk about these not being good for long-term use, that's kind of why you're not getting that deeper sleep, that N3, and so it's one of those situations where it can help you get to sleep, and you might help the anxiety that you're feeling beforehand, but long term, it ends up causing more problems than it's worth.
Right.
They all carry a box warning for, watching for patients who are using these in combination with things like opioids or alcohol, things like that. They can also lower your central nervous system activity, and then being aware that they do have a high abuse and addiction potential. And then there's also dependence, withdrawal, reactions that can happen as well. So that's the other thing. If you have a patient coming to you that's been on benzos for, years in some cases, that's not the point where you go, you know what, it's time to make a change. You stop all their benzos because they're probably going to have some problems.
Yeah.
You have to taper that off and still be safe about it. And then after the treatment for several months, up to 40, this is based on a few different studies, but up to 40% of patients develop tolerance, if not dependence, to being on a benzo.
Which is significant.
And the other thing is with the rebound insomnia, which is weird because it actually is more specifically happens with the shorter acting agents, is also very common. And again, the controlled substances, you got to follow all those laws and whatnot.
Yeah, I think so. Temazepam is definitely the benzo that I see most often. You would think based on the half-life, triazolam might make sense, but it has its own issues. For instance, it can cause daytime anxiety because it's more related to like a withdrawal between doses, because you completely clear it in about 5 half-lives or so. By the time you take your next dose, you're taking another one, then you completely clear it. So you could have some kind of withdrawal, anxious type symptoms. It also has some interactions. You'd want to use caution or reduce the dose if taken with the CYP3A4 inhibitor.
And that's a moderate or weak.
Moderate or weak.
So that's like usually it's a strong that we don't have to worry about. But in this case, it could be bad.
And along with that, with triazolam and astazolam, patients with compromised respiratory function, you'd want to use caution because of respiratory depression. The long-acting ones, flurazepam and clozapam, may impair ability to operate machinery for several days after discontinuing. So because of the long half-life, you would need to use caution there. Not recommended at all in elderly patients. And clozapam may increase the concentrations of drugs like bupropion and efavirenz, acting as CYP2B6 substrates.
And the bupropion one kind of caught my eye because you could have a patient who you have on bupropion for depression, smoking cessation, whatever, but lowering the seizure threshold is one of the things that bupropion we have to worry about. And if you were to add this drug on there, especially with this long half-life, who knows, you could start causing a bunch of problems from the bupropion on top of it. So not surprising you don't see those used very often.
No, if at all.
All right, so let's jump into our next little group, antidepressants. So the first one we'll talk about is doxepin, which is a tricyclic antidepressant. When you are talking about the lower doses of doxepin, so like 3 to 6 milligrams, you're blocking the histamine 1 receptors with better affinity than the higher doses. It does carry a box warning because of the risk of suicidal thinking behavior in children, adolescents, and adults, but that's the box warning that's on all antidepressant type medications, and something I wouldn't be worried about in someone who's just using this for insomnia. If a patient has obstructive sleep apnea, they have untreated narrow angle glaucoma, or if they have like severe urinary retention, this is not a good drug for them because basically it can cause anticholinergic effects, as we all know from our tricyclics. And so all those problems can potentially get worse. The duration of action is around 7 hours. And so the chances of morning effects are definitely high with this medication, even though it tends to be considered a little bit more safe than some of the other controlled substances. Other adverse effects, we have to worry about things like headache, nausea, diarrhea, hypertension, dry mouth, next day somnolence, and especially if it's taken with food, because that kind of allows the drug to hang around even longer. You're really not supposed to take it within 3 hours of a meal. Take it within 30 minutes of bedtime. So you do have a timing issue there, whereas like the Lunestas and those, you can kind of take it a little bit closer to bedtime or at bedtime. And it is more helpful in reducing awakenings during the night compared to actual sleep onset, just because of how quickly it gets into your system. So I will say I talked to Patrick Key, who's the psych specialist pharmacist. He's been on our podcast several times now. He said that him and some of his colleagues use this quite a bit.
Was he at the VA at the time?
I think he's at the Institute of Psychiatry now.
Now he is. I feel like I see this more in like VA type patients, which is interesting. I don't know why that would be, but.
And I don't know if this is the case, but I imagine like if somebody who has substance abuse issues, alcohol dependence, things like that, this would be the option that I would probably go with.
Right. You'd avoid benzos and even like the Ambiens and things.
Or if there's an underlying depression component, maybe, that would be a good option.
What you see a lot of, as far from the antidepressant class, I feel like I do at least, is trazodone. So that's another option. It inhibits serotonin reuptake. It blocks H1 and alpha-1 adrenergic receptors. So it has a box warning for increased risk of suicidal thinking and behavior in children, adolescents, and adults. So it kind of carries that antidepressant box warning. The most evidence with trazodone is going to be similarly in patients who have depression along with insomnia. And it actually, which we talked about this a few weeks ago, has reasonable data along with an SSRI in general anxiety disorder.
So that combo.
Which,
I don't know if you're in your experience, but I feel like people get nervous about that. Like people, SSRI plus trazodone. That's
because of the serotonin syndrome.
The odds of seeing serotonin syndrome are very.
Which I have seen it, but it was in a dude who had more than just these two things going on.
I mean, the trazodone plus and SSRI has good data in that disease state. So, and also, yes, it has some serotonin reuptake inhibition, but it also is affecting histamine and alpha-1 androgenic receptors. There are other things at play.
So it has other side effects like orthostatic hypotension, priapism, which I had heard that, the histaminergic blocking is just not the best for long-term like sleep, chronic insomnia type deal.
And the orthostatic hypotension, have you ever talked to anybody who's experienced that with this? So I told her I was going to tell the story, but my sister-in-law took this one time for the first time, and she was actually spending the night over here with us because it was a holiday or something. I can't remember what she was here, but was late just because she was going to work that day. She didn't work the holiday. She was late to hearing our alarm, jumped out of bed, ran, and she went up the stairs, and then all of a sudden I just heard like boom, and she got to the top of the stairs and just straight fell backwards.
She literally jumped out of bed.
And then ran through the living room
to the stairs.
And just, I was like, well, she's going to have a traumatic brain injury. She fell so hard and she doesn't have any memory of it. She just said she got to the top and just everything went black. I've talked to a few, so I've seen it and I've talked to a few people. So the moral of that story is you please warn people about the orthostatic hypotension, especially elderly patients, because she's not elderly and she still ricocheted her head off the ground. She's fine now, by the way, which is why I can warn. Yeah, she's totally fine. But she was concussed for sure. But now we laugh about it. But older patients, and then starting off at a lower dose, and at least warning patients about that. I feel like that's something that's always in the textbook, so we just kind of like sometimes blow past it. It's important.
Real life consequences.
Yeah,
we'll blow past the priapism though.
Yeah, could you imagine? That's all. How many emails we'll get? I had priapism with this. It's Cole's fault, everyone. Mirtazapine. So this is one that I almost didn't even think about including, but there is enough people that try to use this for sleep. It's a tetracyclic antidepressant. I'm sure all of y'all are familiar with mirtazapine when treating depression. It's going to increase the release of norepinephrine and serotonin. It also blocks different serotonin receptors, so like 5-HT2A, which is why we don't necessarily think of like the sexual dysfunction and things like that as much with this compared to some of our SSRIs and whatnot. It also will block 5-HT2C, that serotonin receptor, which is why the hunger and the weight gain is so prevalent. And it also has high affinity for histamine 1 receptors at lower doses. And so as the dose increases, the affinity for that histamine 1 receptor also that decreases. So it's an inverse relationship. I actually saw this where a patient was started on a very low dose of mirtazapine, and it was helping with their sleep, and so, but not quite all the way there. And then they, whoever it was, their primary care bumped it up to 15 milligrams, I think it was, and then had it scheduled to go up to 30 after that. And basically, the patient, and once they got past 15, they're like, it just stopped working. And they're like, well, I guess it just stopped working. I'm like, no, decrease the dose.
There's a reason.
So yes, in low doses, or if you are, just a side note, if you are giving this to someone who is taking it for depression and they're complaining about the sedation, tell them as the dose goes up, that'll go away in most patients.
Yeah.
But a lot of different adverse effects, QT prolongation, potentially appetite and weight gain are the two biggest things people complain about, anticholinergic effects. So this is one that I would personally try to stay away from in most cases. It's not my favorite for sleep, just because of some of the side effects and issues like that.
You'll also hear about Elavil a little bit.
I like doxepin better than
probably go doxepin over Elavil.
Yeah, but it's definitely cheaper.
They might do it in the case of
definitely cheaper.
It's cheaper. They might do it in the case of like migraine plus insomnia or something like that. So there's another class called orexin receptor antagonists. I believe we have 3 drugs in this class that are approved for insomnia that are reasonable options. So there's Belsomra, suvorexant, blocks the orexin 1 and 2 receptors, can cause daytime drowsiness and next day driving impairment. So you need to warn patients about that. This is more common in female patients and patients who have a BMI greater than 30, interestingly. It can cause patients to experience sleep paralysis. Look that up. It's crazy. Hallucinations and cataplexy. So those are all pretty concerning side effects that you would want to warn patients about, especially sleep paralysis. Look it up. It's crazy. Should be taken within 30 minutes of bedtime. Can cause cough, dry mouth, diarrhea, dizziness, and has some interactions with 3A4 inhibitors. So you would have to start the dose lower with a strong 3A4 inhibitor, 5 milligrams in particular. If it was moderate, like those high as 10 milligrams would be the starting dose.
And then we have lemborexant, which is another drug in that class. And if you're not familiar with orexin, basically think of orexin as being a neurotransmitter that promotes wakefulness, so to speak. So instead of causing the hypnotic effect, the sedation on the benzo side of things, we're basically blocking the neurotransmitter that's responsible for making us feel awake in the first place. You're kind of coming at it from a different, the other side of the spectrum. So the idea of it's really, pretty solid, but that's when we talk about orexin, that's what we're talking about. So lemborexant is going to bind to both orexin receptors, has a little bit more affinity for orexin 2. It still can cause the daytime somnolence, next day driving impairment, things like that. Same, more commonly in female patients with BMI greater than 30. Same issues with sleep paralysis, hallucinations, those types of things like Cole mentioned. And patients that take it with food, specifically a high fat or high calorie meal, you decrease the max concentration of the drug by 23% roughly. And it does still have the interactions with CYP3A4. If it's a moderate 3A4, then it's like contraindicated to use this medication. It's a really strong interaction. And then max dose of 5 milligrams if you're taking it with a weak CYP3A4. So just remember to always check your drug-drug interactions with these orexin inhibitors.
Yeah, definitely. The last is daridorexant QUVIVIQ. So it's going to be very similar to Belsomra in its mechanism, as well as side effects. So next day drowsiness and driving impairment in the similar female patient population and patients with BMI greater than 30 can also cause sleep paralysis, hallucinations, and cataplexy. Should also be taken within 30 minutes of bedtime. But the drug interactions are more similar to the lemborexant, and that would be avoid with strong or moderate CYP3A4 inhibitors. And I believe the QUVIVIQ and the Dayvigo are newer.
Yeah, they are. All right, so let's talk, last but not least, we'll talk about our melatonin receptor agonist. So we have Relmeton or Rosarem. This is the melatonin type 1, which melatonin type 1 receptors promote sleep onset, and type 2 receptor agonists, so which is the type 2 is more responsible for synchronizing like your sleep-wake phases. It doesn't affect type 3 receptors, and it's going to bind to melatonin receptors with greater affinity than actual melatonin does. Ideally taken 30 minutes before bedtime on an empty stomach. A couple things to keep in mind. It can increase prolactin levels in females. It can lower testosterone levels in males. And common adverse effects in morning sleepiness, fatigue, and probably one of the weirdest side effects, exacerbated insomnia. So that's not great. Also, too, you have to watch if it's being used, if there's any concomitant use of a CYP1A2 inhibitor. Specifically, a lot of that data comes from giving this with fluvoxamine. That can cause a lot of issues, so that's contraindicated with any 1A2 inhibitor. And typically associated with, not typically associated with dependence or tolerance. I don't think we mentioned, but the orexin inhibitors, the 3 in that class are all controlled substances as well. So this one is not. So that's one thing that's good. But it's really only going to be effective for like isolated sleep onset. It's not going to help to maintain sleep. And if you look at a lot of the guidelines from around the world, a lot of them recommend against using Ramaton and OTC melatonin because the placebo-controlled studies are just extremely unimpressive.
Yeah.
So these are the ones that I personally try to stay away from.
I wonder if the safety studies for actual melatonin, which who knows how many there are of that, show any issues with the prolactin or testosterone.
It's a good question.
You know?
Yeah.
Like,
I can't imagine.
A lot of people take melatonin.
They do. I feel like I would be surprised if it was
not potent enough.
Yeah.
I mean, some people take some whopping doses of that stuff.
That's true. Well, it's doing a whole lot of nothing. No, but I have my thing with melatonin is like if you're taking, as long as it's a reasonable dose, because there's a huge placebo effect with melatonin. Like I don't think there's really been any concrete, well-produced studies that have showed a benefit with melatonin. My thing is like people who swear by it, great, keep taking it. Yeah, because it's not really going to cause a lot of trauma.
Yeah, if you try it and you feel like you're going to sleep better and you're functioning well during the day.
Unless we find out later on that it increases your prolactin in females and crashes your testosterone guys.
Turns out you got low T, but you're sleeping better.
Do not quote us. All right, let's put it all together.
Yeah, so we'll put it all together. So we went through each kind of individual section, but as far as where to use them and when to use them, with sleep, it is difficult. So we're, of course, doing the CBT-I first line as well as the sleep hygiene, if possible, and if the patient's open to it. But then the next thing is where we need to identify what is their complaint. Is it sleep onset insomnia, or is it sleep maintenance, or a combination of the two? So we talked about what those mean. Sleep onset being difficulty falling asleep within 30 minutes. And once asleep, the sleep quality and quantity are good, and you're not really dealing with awakenings. With the sleep maintenance or mixed insomnia, it's more difficulty sleeping through the night, and your wake ups are about 30 minutes or more, but you're going to sleep just fine. So if it is sleep onset is your issue, and you desire to avoid a first line benzodiazepine receptor agonist, and specifically with that, we're more referencing the non-benzos. But it would include benzos, include the old ones too. But like when you see that, you think old benzos. But if we're trying to avoid the non-benzos first, so there are guidelines that recommend against the use of Ramelteon. Up to date would recommend in this instance the use of Ramelteon for sleep onset if you're not going to use one of the medications that act on the benzodiazepine receptor, and probably due to like lack of efficacy with the other ones. And then they would say consider an herbal off-label or over-the-counter option. So a sedating antidepressant like the ones we talked about, short-term use of diphenhydramine or doxylamine, which we didn't really talk about, but really that should be limited to just a few days for like an acute situation, I would think. Yeah. Or melatonin, and we gave our opinions about that.
So basically with that first block, we're thinking, for us, I'm assuming you agree, I would go either trazodone or doxepin.
I think so.
Yeah, and then Ramelteon maybe can go on the back on the shelf.
And that's if you want to avoid one of the benzodiazepine acting agents. And what are those situations? Maybe a patient has a concern about it, which is reasonable.
Substance use disorder.
Substance use disorder. They're on a lot of other CNS depressing agents, and you're concerned about that sort of thing. Elderly. but if you're not concerned about that, then you would probably go with one of those. So the UpToDate says Rameltion's okay here too, but otherwise you would do a non-benzo, like isoprolol, Zolepilon, Ambien, and then consider the antidepressants
as well,
possibly melatonin, possibly OTC stuff. That's if it's sleep onset. If it's sleep maintenance or it's a mix of the two, and you want to avoid one of the benzodiazepine receptor agonists, then this is where the DORAs come into play. The orexin receptor antagonists come into play. So you could consider one of those first line of the three that we talked about, or low-dose doxepin here would be first line.
But remember, those are still controlled substances.
They're still controlled substances. So if the controlled substance reason is why you're not using the other ones, then that doesn't really fit here.
Right.
Still controlled substances. And then you could also consider other antidepressants. Gabapentin they include here, and OTC medications. If you don't care about the benzodiazepine receptors, first line, you can consider the DORAs, low-dose doxepin, the non-benzos, and then consider the other antidepressants, gabapentin, OTC meds. Nowhere in UpToDate's algorithm do they include the traditional benzodiazepine receptor antagonists. So I think you could probably get pretty far with the sedating medications we have now without having to use temazepam, triazolam, or the other,
especially flurazepam,
or especially the ones that aren't used,
or especially the ones with a 4-day half-life,
or Klonopin, or diazepam, or alprazolam, any of that stuff. I think we can get pretty far without having to include those. Even if the patient has an underlying anxiety disorder, treat the anxiety per the appropriate first-line algorithm. Don't just try to combine those two into a traditional benzo.
Right. Absolutely. And then last thing is there was a meta-analysis that was published in Lancet in July of 2022, and it was titled "The Comparative Effects of Pharmacological Interventions for the Acute and Long-Term Management of Insomnia Disorder in Adults." And so just to touch on a couple points, they said overall escipicolone and lemborexant had a favorable profile as far as, efficacy and use in a real patient population or populations. Escipicolone, they do say that it might cause substantial adverse effects because a little bit longer half-life, the metallic taste, things like that. The safety data on lemborexant were sort of inconclusive, probably because it's just a newer drug. We don't have as much post-marketing surveillance. Doxepin and Zaloplan were well tolerated, but the data on efficacy and other important outcomes were scarce and were hard to make any kind of firm conclusions based on. So I think a lot of that stuff, like the Doxepin, for instance, is more anecdotal evidence or special cases with Zaloplan, like using that as needed if they wake up in the middle of the night. Benzodiazepines, daridorexant, suvorexant, and trazodone can also be effective in the acute treatment of insomnia, but were associated with poor tolerability, and they all lack information about long-term effects and how patients respond long-term. And then they closed with melatonin and Rameltion did not show any overall benefit, so probably not a good option. So even Lancet kind of making fun of those options. But it's still, I'm glad they did a meta-analysis like this. It's still not super crystal clear as far as which one to actually utilize. So I think you have to kind of, at least what I do in my mind when I'm trying to come up with a treatment algorithm is that patient specifics, looking at something like the UpToDate algorithm, and there's other guidelines as well, and then taking things like this meta-analysis, and then I try to just put all that together and pick whatever may be right for that particular patient, I think is, at least my strategy for kind of handling this, which is one of the reasons why I like pharmacotherapy. It's a big, giant puzzle that you got to make fit together.
Anything with the brain is just not clear-cut.
Right.
Anything.
And what works for some patients may not work at all for others, and you got to try some things. So it's definitely much, much harder than just give them Ambien, get them out of here.
Yeah.
6 refills. So, it is.
And then we have nighttime turkey fiascos.
Yeah. What if it was the best turkey you ever made, though?
I know.
That'd be interesting. All right, guys. So thank you so much for listening. Thank you so much to Free CE for continuing to partner with us. And, it's been probably a year and a half since we started with them. So we have a ton of episodes on the website now, on their website, that you can get credit for, which licenses for some of you are going to be coming due here in the next few months. And so get your CE credit in and make sure you check out all their content on the website if you have not done so already. If you're tired of our little tangents that we go go on and want more straightforward, like nerd style lectures, then we have a treat for you, which is our Patreon account. So it's a subscription service. It's $3 a month, or it's like $36, maybe $33, maybe something like that, maybe even less, for a year's supply. You get access to all the Patreon lectures, which are actual lecture style PowerPoints. You get to download all the PowerPoints. And it's just lectures that I prepared. I might tweak certain things, but lectures that I prepared for the PA students for the college that I teach at. So make sure you check that out. I've gotten a lot of good issues, or a lot of good feedback, not issues, a lot of good feedback from the patients who have used. In fact, a few people have said they've used our podcast and the Patreon to help study for boards. So if anybody asks, we're basically a board certification study group.
Might as well be.
And we're going to start doing some like live cases on Patreon as well. Got some other things in the pipeline for 2023. So make sure you check that out. Huge thanks to Pearls. If you have not checked out the app, Pearls, PYRLS.com/CoreConsultRx. It's drug information application that's been making upgrades literally every month the entire year, but they've sponsored us this whole year, and so really appreciate their support. They've been outstanding, and if you have not checked them out yet, make sure you go to that link in the show notes. Again, pearls.com/CoreConsultRx. You sign up for a free account, check it out. You get some free treatment algorithm like PDF files and things you can keep, and if you like it, you can always upgrade to the paid version, which is still very reasonable. If not, no harm, no foul. But appreciate them. If you want to contact me or Cole or even AJ, if we can find him when he's on vacation, our emails will all be in the show notes. You can text us directly at the number that's in the show notes and reach us on any of the social media platforms, and we'll do our best to get back to you as quick as we can. As always, thank you guys so much. Make sure you go to the link to get the post-activity test for your unlimited members, for ECE people. And the password again is SLEEP, all capital letters. Thank you guys so much. We'll catch you in the next episode. Have a great one.